Welcome, everybody, to the Asthma Quality Improvement, Building Knowledge, Confidence, and Change in Primary Care Providers. This is technically the first wave. It's kind of a relaunch from 10 years ago, so we're calling it Wave 1, and you are in the second action period call. Thank you to our program partner, ODH's Asthma Program. And a little switch on the agenda today, but everything else holds. Want to welcome all of you. We'll hear from Zainab with some data collection tips on what she's seeing submitted so far. We will have Dr. Cuff talk about asthma in sports, and then Nurse Karen teach us how to use the asthma action plan and asthma device education. And then if there's time, next steps from me, but if not, I will email those out. So welcome, everybody. If you can do so safely, please share your name and your practice in the chat. And if you have explored the newly added resources on the asthma program website, we talked about this kind of on the kickoff call and how it's going to be a home base for the program. Dr. Marco and our team were able to kind of go through what is relevant around SMART and GINA and NHLBI, and we uploaded those on the program website. And Zainab, you want me to stop sharing?
Yes, please.
Okay.
So today I'm going to share with you what the data looks like initially. And it's going to look, I'll have it in an Excel spreadsheet for now. But as we move forward, I'll send individual slides with individual data, but also share with you what the aggregate data looks like. So I wanted to thank everybody for submitting baseline data. I know that it takes some time and it's cumbersome sometimes, but I've noticed that some practices, I know that we specifically requested 3 months of data. I think it was October, December, and either March or April.
January.
Yeah, January and April. I'm sorry. And we've had some practices that have submitted data, but it doesn't belong to any of those months. So from my perspective, I thought it would be better to combine all of that data into one baseline point. So I know that you have the metrics that we're collecting data for. And I also wanted to remind you in terms of the data collection tool, I understand that some of these metrics are collected technically in one section and it just has check marks. So you can choose multiple checks for that one section. Please make sure that you're selecting everything that's true, especially during QI, just to give yourself credit for that. So we're looking at assessing asthma, assessing the symptoms, assessing asthma symptoms, and then we're looking at whether or not an action plan was either edited or put in place. And we're also looking at environmental triggers. And I understand, again, that all of those are collected in one portion of the data collection tool. So I just wanted to remind everyone to read through that carefully and make sure that they're selecting everything that applies. So in baseline, we're looking at optimal asthma care, which is a combination of assessing their symptoms, putting an action plan in place, and looking at any environmental triggers. Only about 30% of the patients that are seen by all the practices in total are receiving optimal care for asthma. In terms of assessing their symptoms and the severity of their symptoms, over 50% of the patients are being screened for that. In terms of diverse patients, it looks like a lot of the patients that the majority of the practices are seeing have a diverse background, either through race or through socioeconomic status. And I want to remind you that we would really appreciate, for that information to be as correct and as accurate as possible. In terms of the action plan, again, about 60% are receiving an action plan, either whether it's a new plan or whether it's a plan that was already in place that is changing depending on the symptoms of the patient. In terms of environmental triggers, a little less than 50% of the patients are being asked or screened for that. Self-management materials, again, we understand that you probably don't have any asthma material already in office, but I know that the AAP does provide that. So we are hoping that regardless of how severe or how bad the symptoms are for the patient, that they are receiving some of those materials to help manage or to help the parents manage their kids' symptoms, to see what kind of triggers there could be, anything that could help improve the quality of life of those patients. Um, and this number I was pleased with, in terms of patients with persistent asthma. Over 95% are on controller medication, and we hope to keep that number as high, that high or even higher, close to 100%. In terms of vaccines, specifically the flu vaccine is what we asked about. The majority, again, of the patients are current on their flu vaccines, are current on their vaccines in total. Another metric that we're really trying to look at is, trying to decrease ER visits and hospitalizations due to asthma. That the numbers are pretty low. We're trying to potentially bring them even lower. We have faith and confidence in your abilities to control your patient's asthma. So we're really trying to see these numbers a little lower as we move through the project. But again, here we have about 21% of patients that have visited the hospital in the past year or visited the ER, and only about 11% of those were hospitalized. So that's what I have prepared for today. And on our third action period call, this data will be displayed in a figure with this baseline point, as well as some of the QI data that you've already been collecting. I don't know if we have time for questions, but if anyone has any questions about the data collection tool, I can answer them or Brooke can answer them. But please, if you have any questions, just go ahead and ask. It's better to get your questions out of the way in the beginning so that we can see if anyone's having trouble with the way that they're inputting any of their data, so that we can fix that here at the beginning before we keep moving forward with our project. But if no one has any more questions, I can hand it back over to Brooke.
Thanks, Zainab. I do want to give credit to everyone who has reached out with questions. We've been able to get those answered. And then if not, I can always send them to Zainab for more information. Thanks, Zainab.
You're welcome. Thank you.
This disclaimer from ODH applies to both presenters today. And Dr. Cuff.
Thanks for having me. I'm going to talk to you a little bit about asthma and sports and athletes. If you want to go to the next slide. So I'm going to start by just defining some common conditions associated with asthma in athletes, describe the evaluation of these conditions, and then discuss some of the challenges in managing asthma in athletes as well. Next. So there's definitely some specific issues to be aware of when managing asthma in athletes. And I think this table, which was taken from a 2015 New England Journal of Medicine article, summarizes them pretty well and really sets the stage for what I'm going to talk about over the next 20 minutes. First off, poor recognition of or difficulties in assessing asthma symptoms occur often in athletes. Unrecognized alterations in lung function may be present because despite bronchoconstriction, expiratory flows may look normal due to high baseline values in well-conditioned athletes. Also, the initial testing may be normal, requiring repeated testing during high-intensity exercise or in training in the environment in which the athlete participates. There's also an increased prevalence of coexisting conditions in athletes with asthma, such as ELIO, which we'll talk about in a second, rhinitis, and GERD. Under or over treating is common, and athletes sometimes have poor control with their current therapies. It's also essential to avoid developing tolerance to beta-2 agonists in athletes, as with anyone. It can sometimes be difficult for athletes to reduce exposure to the sensitizers and irritants that they're exposed to while training or competing. And then finally, anti-doping regulations have to be considered, at least in college or elite athletes, so they're not using banned substances. Next slide, please. So I'm going to talk about a couple different conditions here. It's kind of like an alphabet soup, I think, when we're talking about respiratory conditions. But I think exercise-induced asthma and exercise-induced bronchospasm are sometimes used interchangeably, but they really should be considered two distinct entities. So exercise-induced asthma is used in those who carry a previous diagnosis of asthma or have abnormal resting lung function, while exercise-induced bronchospasm refers to a transient airway narrowing that's only experienced with exercise and can be thought of as a distinct form of airway hyperresponsiveness. And then I put up vocal cord dysfunction, or what's more recently been termed exercise-induced laryngeal obstruction, because it can mimic the symptoms of asthma or bronchospasm in athletes. But VCD refers to the paradoxical closure of the vocal cords or supraglottic tissues, most often during inspiration, less commonly during expiration, that results in extrathoracic airway obstruction. Next. So as you're probably aware, there are many benefits of exercise. In kids with asthma, exercise training can increase exercise capacity and fitness. It can increase physical activity and quality of life. It can decrease asthma symptoms and exacerbations, and also decrease airway responsiveness and EIB. Next. But unfortunately, 80 to 90% of kids with asthma will have symptoms that are triggered with exercise. Therefore, good control is really crucial to allow kids with asthma to help reap the benefits of exercise. Next slide. When we talk about the epidemiology of EIB, the rates really range from about 9 to 50%, and much of this variation is due to differences in the population studied and the methods used to make the diagnosis. But in general, a higher rate of EIB is reported in elite athletes and those who compete in colder conditions. Next. So there's really two main theories on causes of exercise-induced bronchospasm. One is the water loss theory, and this states that large volumes of dry air that's inspired during exercise kicks off a cascade of events that result in evaporative water loss from the airways, activation of mast cells and epithelial cells in the bronchial mucosa, and a release of inflammatory mediators, which causes increased osmolarity of the extracellular fluid and therefore airway narrowing. And then there's also the heat loss theory, which states that relatively cold air inspired during exercise causes pulmonary vasoconstriction, followed by reactive hyperemia of the bronchial vasculature to rewarm the airways, accompanied by increased hydrostatic pressure in the capillary bed, leading to airway edema and narrowing. And then further contributing to the problem is the release of mediators like histamines and leukotrienes that can result from contact with the cold or dry air with the airway, as well as from airborne allergens, pollutants, or irritants like chlorine in a swimming pool. And then the hyperventilation associated with exercise exposes the airway to increased loads of these substances. It's also been speculated that exercise itself may lead to mediator release based on some unknown mechanism. Okay, next. So the symptoms of EIB include cough, wheeze, chest pain and chest tightness, shortness of breath, excess mucus production, and fatigue. But in general, symptoms alone are really not very good predictors of EIB. But cough and chest tightness have been shown to be the most sensitive of all of them. Then when we talk about vocal cord dysfunction, they can also present with shortness of breath and chest tightness, which can sometimes make for a confusing picture. But it can often be distinguished from EIB because of symptoms of upper airway obstruction, such as stridor, throat tightness, voice changes, or a choking sensation. Next. The timing of symptoms in the two disorders is also different. With exercise-induced bronchospasm, require generally at least 5 to 10 minutes of intense exercise, during which time the bronchodilation is maintained, and then symptoms peak at that point and persist for 30 to 60 minutes if left untreated. Interestingly, there appears to be a refractory period in about 50% of athletes that lasts for anywhere from about 1 to 4 hours, during which time identical levels of exertion will produce a less severe reaction. In contrast, vocal cord dysfunction usually has an abrupt onset soon after exercise begins and resolves within about 5 minutes of cessation of activity. The symptoms are also highly variable and notoriously difficult to reproduce. There's really no refractory period in these athletes, and they can frequently suffer severe repeated attacks immediately upon restarting activity. Next slide. So I mentioned symptoms are unreliable. About 50% of those with shortness of breath and chest tightness will not end up having proven EIB. Even cough, which is the single best predictor of EIB, has only about a 61% sensitivity and 69% specificity. And this holds true for youth athletes, high school, college, and elite athletes. So therefore, really some form of objective testing is necessary to make the diagnosis. And most experts would recommend starting with just baseline PFTs to rule out underlying asthma if this is somebody who does not have a known diagnosis. If these tests are normal, then some type of bronchoprovocation testing is needed. So this consists of some measure of lung function, most commonly FEV1 in 1 second, before and after some type of bronchial stress. You can also use peak expiratory flow rate, and some like it because of the convenience in field tests, but it tends to be a little bit more effort dependent and therefore not as accurate. And then a fall of 10% after bronchoprovocation is abnormal, although some tests require 15 to 20% change for a diagnosis of EIB. Sorry, let me see if I can turn that off.
Okay, we're not hearing anything.
Okay, sorry, there's a printer next to me, which is going off. I'm in a shared workspace. So before we get into talking about the various types of tests, just want to make you aware of some other things to keep in mind on your differential in these athletes. Exercise-induced laryngomalacia or hyperventilation, cystic fibrosis, interstitial pneumonitis, cardiac problems like arrhythmia or structural heart disease, chest wall abnormalities, and GERD. Next slide. So exercise-induced bronchospasm tests can be separated into 2 basic categories, indirect and direct, each with their own advantages and disadvantages. Next slide. The exercise challenge test is the most commonly used. In general, it requires about 6 to 8 minutes of exertion at 85 to 95% maximal heart rate. And then PFTs are measured before and after at various intervals of the challenge, most often about 5-minute intervals for half an hour. And then abnormal PFTs at baseline obviously may indicate pre-existing asthma, whereas a decrease of 10 to 15% from baseline in the selected parameters are diagnostic of EIB. If the results are unclear or confirmation testing is desired, then there's other tests available as well. Next slide. So there's really 2 subtypes of exercise challenge. There's the laboratory challenge and the free exercise or field challenge. So the lab test can be done either on a treadmill, which is most common, or a cycle ergometer. And the field challenge typically employs free running, but really the athlete sport of choice can be used instead. The major advantage to the laboratory test is it has a high specificity and you can control the air temperature and humidity in the environment. The disadvantage is that you can often fail to induce bronchospasm in elite athletes. It's not sport specific and it's not performed in the athlete's customary environment. The field challenge, on the other hand, has a little bit higher specificity and does allow testing within the athlete's environment, so exposure to whatever the pollutants or irritants may be. The disadvantages are you can't control the conditions and you can't standardize the workload as well. Next. So eucapnic voluntary hyperventilation testing is what's used by the International Olympic Committee to diagnose exercise-induced bronchospasm. It doesn't involve any exertion, but instead relies on mechanical factors to induce bronchospasm. EVH involves inhalation of a dry gas, which contains 5% CO2, 21% oxygen, and 74% nitrogen for a set period of time based on a specific protocol. And so there's a single-step protocol for those with mild asthma or suspected EIB, where they hyperventilated about 85% of their predicted maximum voluntary ventilation for 6 minutes, or a multi-step protocol for more severe disease, which is a little bit more of a gradual ramp up. And for this test in FEV1, a decrease in FEV1 of greater than 10% is diagnostic. The advantages here are high specificity and a higher sensitivity than the exercise challenge. It's inexpensive and easily standardized, and you can achieve high ventilatory rates. The disadvantage is, again, you don't expose the athlete to their usual environment, and it's just not practical in most clinical settings. Next. And then the final type of indirect challenge is the asthmatic challenge. This classically involved inhalation of a hypertonic saline, but it can also use a dry mannitol powder. And these tests induce the same hypertonicity and hyperosmolarity with subsequent mast cell degranulation and inflammatory mediator release as exercise and EVH testing. They can be done safely by administering progressively increasing doses of the osmotic agent in a controlled fashion, measuring FEV1 after each dose and looking for a decrease of more than 15%. Next. The advantages of the osmotic challenges are they're inexpensive and well tolerated, both sensitive and specific. The disadvantages, again, you don't expose the athlete to their typical environment. They can be lab dependent and in some cases may cause a transient cough. And then the other type of challenge is a direct challenge, which involves administration of pharmacologic agents that act on airway smooth muscle, typically histamine or methacholine. They're performed similarly to the osmotic challenges, but require a decrease in FEV1 of over 20% to make the diagnosis. The advantages to the direct challenge are they're safe and readily available. The disadvantages, they have a little bit lower sensitivity and specificity. They're more expensive, again, lab dependent and not exposing the athlete to their typical environment. Okay. Another thing that some physicians will do is just a medication trial with albuterol. It's definitely quick and easy, but it's not ideal for a couple of reasons. So as I mentioned before, patient symptoms have poor sensitivity for predicting exercise-induced bronchospasm. And certainly some patients managed in this fashion will have, true EIA or EIB and benefit from therapy. The problem is that other athletes without it may respond through a placebo effect and then be maintained on a medicine with potential side effects. This is probably less of a concern in those who have a pre-existing asthma diagnosis and are already taking it, but just something to be cautious about with overuse. Okay. So now we're going to talk about treatment. So the main goals of treatment in athletes are to achieve and maintain asthma control, as with anyone, to inhibit or minimize the EIB to avoid the adverse effects on performance, to prevent risk factors for acute events and exacerbations, to decrease the risk of reduction of lung function, and to ensure compliance with sports authorities' regulations of substance use. We can always try non-pharmacologic treatment first. So environmental alteration would be your first step. Because I mentioned cold and dry air is a potent stimulus, exercising in warmer, more humid environments when possible can reduce symptoms. Also trying to avoid exposure to pollutants and allergens. Unfortunately, this isn't typically feasible, especially for winter sport athletes, because, they really have to train in those conditions for their sport, in which case wearing a mask can confer some protection. Nasal breathing also helps in a similar way to help warm and filter and humidify inspired air. Because of that refractory period that I mentioned in some athletes, trying a pre-exercise warm-up where they maybe do 10 to 15 minutes at about 50% intensity before competition to bring on some of the symptoms. And then when they have their actual competition later, if they do get it, those symptoms tend to be a little bit less severe. And then finally, identifying and treating any coexisting conditions like GERD and rhinitis, and then providing asthma education whenever possible so that athletes understand the condition and what they need to do to help manage it. And then we'll get into some pharmacologic treatments that I'm sure you guys are very familiar with. Next slide. So short-acting beta-2 agonists are, typically are the mainstay of treatment. 2 puffs taken 15 to 20 minutes before exercise, ideally with a spacer. The advantages to these agents are they have immediate onset of action, they're relatively inexpensive, and confer about 80% protection. The disadvantages are that protection typically only lasts for a couple hours, and daily use can decrease the effectiveness of the medication really in as quickly as about 1 week through downregulation of the beta-2 receptors on the mast cells, which leads to an increase in mediator release. They also have some side effects, tremor, and tachycardia most prominently, and they're banned by the NCAA and WADA, the World Anti-Doping Association, at higher doses, although they're okay as long as they have documentation that their use is required. Next slide. So as you probably are aware, in 2019, the Global Initiative for Asthma, GINA, came out with guidelines that said that there's no longer recommended to treat asthma in adults and adolescents with a short-acting beta-2 agonist alone, and that all adults and adolescents should receive an inhaled corticosteroid-containing controller medicine, either as needed for mild asthma or daily to reduce the risk of serious exacerbations and to control symptoms. So just keep that in mind when using the short-acting beta-2 agonists. Okay. Long-acting beta-2 agonists can also be used. Things like salmeterol and formoterol are most common. They can be taken about 30 to 60 minutes before activity. They're effective for a longer period, about 6 to 12 hours. But again, daily use can lead to tolerance, but it takes a little bit longer, usually about 8 weeks. But if you can, limit their use to less than 3 times a week, then oftentimes you can avoid that tolerance. Just to note, there have been concerns about adverse events in these medicines and use in chronic asthma. So monotherapy associated with increased asthma-related mortality and non-fatal serious adverse events. So generally not recommended for daily use as a single therapy. And again, NCAA prohibits these without documentation, and WADA prohibits them, at least salmeterol, with higher doses. Another medicine that can be used are the leukotriene receptor antagonists, so montelukast and zafirlukast. The advantages to these, that they can be effective in a single dose, provide protection up to 24 hours, don't seem to lead to tolerance. They may be particularly helpful in atopic athletes, and they can also be used as a controller medicine. The disadvantage is they generally confer incomplete protection. And then mast cell stabilizers like cromolyn sodium and indocromil are typically used more as second-line agents. They can be used immediately before activity and again be effective in a single dose, do not lead to tolerance. The disadvantages, they're effective for less than 2 hours. They confer incomplete relief and are totally ineffective in some patients. Inhaled corticosteroids, generally a controller medication when episodic prophylaxis is unsuccessful, should be used if daily use of the other treatments is required. I would say at this point, you may want to think about getting pulmonology involved as well if they're not already. And these have to be used for at least 2 to 4 weeks before you can start to see effects. And the final medicines that have been used a little bit more recently are your antimuscarinics, so atropine and ipratropium. They act by competitively inhibiting acetylcholine at the muscarinic receptors, which leads to a decrease in vagal tone, bronchial hyperresponsiveness, and reflex bronchoconstriction. They're safe and effective, but have a variable response.
Dr. Cuff, I want to be mindful of time. Do you want to pause here and see if there's any questions?
I do. I was going to say the rest of the slides refer more to vocal cord dysfunction and exercise-induced laryngeal obstruction. So I really put them in there just for reference to see if you can, send out the slides. If you want to distribute the slides at some point, then can have a little bit more information on that. But yep, that pretty much wraps up the asthma portion.
Okay, good. Any questions real quick for Dr. Cuff? You can always send them to me and I can forward to him also. That's an option. Okay. Dr. Cuff, thank you. I will send anything your way. I appreciate your time today.
All right. Thanks, Bert.
Have a good day. Bye-bye. Okay. I will send these out. You get some good bonus. If you think of any questions, please don't hesitate to put them in the chat or email me. Okay. And Nurse Karen, I have your slides.
Hi, I'm Karen Ponomarenko, and I've been at Rainbow and Babies and Children's for 28 years and providing asthma education for the past 22 years. And today I'm just going to talk to you about how to teach an asthma action plan and how to use some of the asthma devices to teach patients and their caregivers. Next slide. So I specialize in asthma teaching to our inpatients on a pediatric floor. And I'm a certified asthma educator, and I'm also a certified pediatric nurse. Next slide. So today we're just going to talk about how to complete and explain the asthma action plan to patients and caregivers, and talk about correlating symptoms with zones of the asthma action plan, prescribing and age-appropriate spacers, how to clean and how to use administration techniques, and choosing an MDI inhaler versus a dry powdered inhaler, the importance of medication teach back, and benefits of using a medication picture chart while providing education. Next slide. So first here is an asthma home management plan or asthma action plan. And this is one of many designs that you may see. And in this one, at the beginning of the asthma home management plan, you can see there's an area to specify triggers that might be unique to the patient. Right up on top. And then also there's an area if they have exercise symptoms where they can put pre-treatment medications there. But the asthma home management plans are all designed to be the patient friendly. And so they're easy to follow, they're colorful, and they look pretty happy. So they have a green, yellow, and red zone. You can, next slide. So we teach asthma in a stoplight format. So the green zone is where your asthma is good and they can go play. The yellow zone is they should slow down or caution. That's when with the onset of asthma symptoms. And last zone is the red zone, which is the stop and get help zone. And each asthma home management plan that I've seen has been pretty much set up in this exact same format. Next slide. On the back of the asthma action plan is an example of how to use an inhaler with spacer. We highly recommend that patients use their spacer with their inhaler so that they get the most amount of medication with each puff given. Next slide. So again, this is a pictorial on how to use the MDI with spacer with mouthpiece. And then we also have handouts on how to use a spacer with face mask. And it all depends on age and developmental appropriateness as to which spacer we decide to use for a patient. Next slide. So here is just a smaller version of the asthma home management plan, focusing on the green zone of the plan. So in the green zone, we're hoping that children can play. They have no cough, no wheeze, no daily symptoms. They can sleep comfortably, play comfortably. And so in the green zone, you would add any daily inhaled steroids that are going to be taken, maybe any antihistamines, nasal sprays, montelukast taken daily. And that is to keep them under their asthma under daily asthma control. Next slide. The next zone is the yellow zone of the plan. And this is a very important part of the plan also, because this is what the patients need to do as soon as asthma symptoms start. A lot of people think that you do not need to start treatment until you're really having a severe episode. So I really remind patients and families that they need to start treating as soon as they see those early onset symptoms. So coughing, especially at night, having some trouble breathing, wheezing, it's hard to sleep, or for a lot of our younger kids, it's the start of a cold with a cough that sets off their asthma, and that's when they should begin their treatments. A lot of families also think that you need to wheeze to use their albuterol, and that's not the case. So as soon as those symptoms start, that cough, with or without wheezing, they should begin taking their quick relief inhaler. Next slide. And the last zone is the red zone, and this is tells patients exactly what to do if they're in crisis. So in the red zone of the plan, patients are now having a severe respiratory distress, having a hard time catching their breath, maybe nasal flaring, their ribs may be showing, they may have trouble talking and walking, they might appear more drowsy. So in the red zone, it's usually a very standard plan. With the red zone, we give 4 puffs of albuterol using the spacer, or some patients use a nebulized treatment. Some patients are given an extra order of oral steroids to have on hand. So if they're in a severe crisis, they can take a dose of their oral steroids if prescribed. And it generally teaches that if a patient has received a treatment of albuterol and they've not responded within 15 minutes, they should give another 4 puffs of their albuterol or a nebulized treatment. And if after that giving treatment, if they're unable to space back to every 4 hours, where that's a zone where we're comfortable with everybody taking their treatments at home, they should continue to give treatments by calling 911 or going to the hospital for treatment. They should not try to manage it at home. I always reinforce that, because a lot of people see that we are doing that in the hospital, so they think that they can do it at home. The things that are done in the emergency room, some people think, well, they did it there and they get back to back or continuous treatments and they got better. Well, we have a lot of other support in the hospital that they won't have at home. And are you able to go back to the yellow zone, Brooke? So in the yellow zone, I just wanted to briefly explain. I didn't explain how to explain the yellow zone to a family. So if somebody's in the yellow zone, they start taking their albuterol. Generally, we tell them 2 to 4 puffs or a nebulized treatment, and they can take it as often as every 4 hours throughout the day while they're having symptoms. But if a day or two's gone by and they're not improving, they should get in touch with their doctor, their pulmonologist. Or if they start needing it more frequently than every 4 hours and they can't, consistently stay at that every 4-hour phase, they should be calling their doctor. If patients take their inhalers and they start to feel better, then they can return back to, their green zone, then they can stop taking their quick relief medications. One thing that we do focus on, whether it's the green zone, the yellow zone, or the red zone, is trying to correlate symptoms that patients are having with the asthma home management plan. So if you're doing an assessment and you're looking at the patient, or they come into an office visit and you see that they're coughing a lot, or having with or without wheezing, or just having some trouble breathing, kind of explain that those are symptoms of the yellow zone and they correlate with the yellow zone symptoms. And if they were in the red zone, that we can go back to the red zone now, if you don't mind. There you go. That if they're in the red zone, if you're seeing these symptoms while you're doing your assessment, to point them out so that parents really understand when they see these symptoms, this is what I really need to be doing. So the asthma home management plan is really a valuable tool to have, and we encourage patients to have it at home, at school. I tell people to take pictures of it for their cell phone, so it's available for anyone who needs it if they want to share it with another family member or caregiver. Next slide. And this lastly is just a picture of, which I find very useful. It's from Allergy and Asthma Network. And every year they update this respiratory inhaler sheet here. I find it very useful because a lot of patients have a lot of inhalers at home and they don't know the names of them. They really don't know really why they have them. And this plan really helps us to tell them, identify what medications they're on, and show them what medications they're going to go home on and what medications they are to discontinue. So one thing that I really focus on in showing the families there is up in the corner, you'll see the beta agonists, the bronchodilators, the short-acting bronchodilators. There's so many different colors of them. There's in so many different brands. So, they may get prescribed ProAir, they may be prescribed Preventil or Ventolin, and they're all have different color outside canisters. And like here in the hospital, we use an albuterol that has a white covering on the outside of it. So the part that confuses them is they don't realize that these are all the same medication because they're all different colors. They think one strength is better than the other, one color is better than the other. So I always explain to them that the word albuterol is always on top of those inhalers so that they know that They're the same medication, however, they may look different and they're of equal strength to one another. And then in the rest of the picture chart showing just your inhalers and in general, the inhaled corticosteroids and then the combination inhalers. So this is great because, you know, say for example, they came in on Flovent, but now they're going to Dulera. You can cross that off to remind them that you're no longer taking that medication at home, and this is the new one that you're going to take. And that when they're taking their preventive medicines, their controllers, they're always consistently the same color canister or device. So if you're able to get a copy of those, you can order them from the Allergy and Asthma Network every year. They're really beneficial in helping identify medications that are needed for our patients. Next slide.
Can we pause here for any questions?
I just put in the comments, Karen, just what you said about the yellow zone, just to remind people that the yellow zone can be tailored to their specific medication regimen, whether that they're using albuterol as their quick relief or if they're using the ICS formoterol on the SMART regimen, which is why it's specifically those lines were left blank, so you can customize it for the specific patient and what they're taking.
Yeah, and that basically, based on those new interventions, has been confusing for some parents. So it's really important to take some time really explaining the difference of everyone's used to going to their albuterol naturally when the symptoms start. And it's a culture change now to go to a quick relief inhaler that's a combination inhaler. So it's really important to spend time really focusing on it, and really important that when you're done explaining the asthma home management plan to them, that you're providing the opportunity for them to do teach back. It really, patients and families may seem like they're really understanding, or they'll say, yes, I understand that. And then when I ask them if they could just provide, you know, teach back, and I want to see their understanding of the plan, it's really interesting to see how many people were really actually listening or retaining it, or they're confused and they don't want to actually tell you that. But the teach back really provides an opportunity to see that they understand the plan. And if you need to explain it again to them or in a different way, that gives you the opportunity to do that. We really want to make sure that they know when they're going home, what to do when their asthma symptom starts, what to do on a daily basis, and what to do if they're in crisis. So taking the time to explain that plan is really important. Next slide. Okay, now I'm just going to show you how to use inhaler and spacers. And I'm going to have to show you from a standpoint where everyone able to see my inhaler, my spacer? So here in the hospital, we use just inhalers and spacers for the most part to treat our asthma patients. And when we're giving them their MDI with spacer, we want to make sure you order the appropriate size. So they come in several different sizes. This is a spacer with face mask size small. This is a spacer with face mask size medium. This is a spacer with face mask size large. And this is a spacer with mouthpiece. So one thing that's very important is that when you're a patient comes in to talk to you and they say they've been using a spacer, ask them what it looks like or what, you know, what color it is, because if a doctor does not specify in their prescription what size they should have, whether it be a face mask or a mouthpiece spacer, the pharmacy may just give them whatever they have available. So we'll have, you know, teenagers coming in with this big mask and we can see why they never use it. And then sometimes babies will come in with the mouthpiece spacer, so you can see why it's ineffective. So when they're going home, when they come in, you want to make sure they have the right spacer. When they've been transferred, if they're inpatients from a unit to the floor, or as they grow older, they may still have a inappropriate spacer that they used when they were, you know, much younger, and they're able to transition over to a mouthpiece spacer. So you want to pay attention to that. Basically, these spacers are all used the same way. This large spacer with face mask is generally used for kids who are developmentally delayed, or their face is now too big for this medium-sized spacer, and they're unable to use a mouthpiece spacer. The smaller spacer here is really for kids that are 6 months under preemies, very small faces. So generally, if they're treating with asthma, a lot of those kids have nebulized treatments to give their treatments with for the smaller babies, because they really need to be able to generate enough force to breathe that medication in. So sometimes a nebulized treatment is better than a spacer for those kids. And then this is a spacer that we use for ages like probably 6 months to about 6 years old. This spacer is spacer with face mask size medium. And once they've mastered, they've outgrown this one, they go to the spacer with mouthpiece. So I just want to show you how to use these. Whether you're using the spacer with face mask or the mouthpiece, the technique is somewhat the same in starting. You shake up the inhaler. If it's an inhaler that hasn't been used for a while, such as an albuterol or whatever, they should prime it, or a new combination inhaler that they're using it just as needed. They should prime that inhaler, shake it up, and they're going to place it in the end of the spacer. And then I'm going to bring Radical Randy out here to show you just some of the ways that we use the spacer. So one of my pet peeves is that when patients come in and they need a treatment, that somebody goes up and just shoves the spacer on the kid's face, and it's traumatizing. So instead, I usually like to put it on a parent's face and have them, count to 6 every time they're breathing in and out, and, clap when they're done, or put it on a stuffed animal. And clap when they're done to make it fun. And then hopefully they're willing to try it. Doesn't always work, but it does tend to work a lot. So anytime you're using a spacer with face mask, one of the things that's really important is that it goes over their nose and mouth and has a nice tight seal. So as you can see on Randy, this would be good positioning. And then you'd spray the inhaler and then watch the patient take 6 breaths in and out. So one of the things I tell patients, caregivers, that they could do is watch the child's chest go up and down, or as the child's breathing, you'll see this little valve here moving out each time they're exhaling. So that's how to use a spacer with face mask. And if a child is not cooperative, another thing that we'll do is kind of put the spacer on their face and your hand behind their head, so they really can't get away very easily. Or if it's really a fight, to try to wrap your arms around them and have their legs between your legs and spray it and try to move with them. We really don't want to be a fight, because if they're crying, they're not getting they're getting ineffective treatment. But so that's why we try to offer praise and fun, so they're more cooperative. And then when using a spacer with mouthpiece, this is again for kids like 6 and up. I always tell them the easiest way to do this is to keep their mouth around it from start to finish. So what we do is we tell them to shake their inhaler, whether it's before or after they put it inside the spacer, and then I tell them to put their mouth around the mouthpiece here, and with a nice tight seal. It has to be a good seal around the mouthpiece for it to work. And then what they do is they first, with their mouth around it, breathe in, gently blow out like they're blowing out a candle, and then you have them spray it, and then slowly and softly they need to breathe that medication in and hold it to the count of 10. Exhale out. And then they can do their second puff, or however many puffs that they need with it. All of these spacers come with their own cleaning instructions, and one they get from their pharmacy may look different than the ones that we use in the hospital. So we always tell them it's very important to clean it after. Patients that are taking an inhaled steroid twice a day, I usually tell them to do it at least once a week. And patients that are using it intermittently because they're having starting symptoms, I tell them to wash it definitely by the end of the episode. They can rinse it off and dry it, but the problem is if they need a treatment before it dries out, there's fluid inside there, so you don't have them wash it after every treatment. And the way to wash this one is they just take whether it's a face mask or the mouthpiece one, is they just take this bottom end off only, and this comes with a cap on it if it was an original one. And they take the pieces, they put it all in warm soapy water, soak it for 15 minutes. Dish soap is fine. Rinse it in clean water, and then they air dry it upside down. They're not ever supposed to put anything inside of it to clean it with or dry it with. So no baby brushes, no towels. It still looks filmy after they're done cleaning it, but that's fine. That's appropriate. And I let them know that it will look that way, but you know that you cleaned it, so it should be good to go. Putting anything inside of it tends to ruin the effectiveness of the spacer. And I think more medication ends up on the inside of the spacer than it does in the lungs if you're destroying the mechanisms of the spacer. Do you want to add anything to that, Angela?
No, the only thing is most of the spacers with mouthpieces also come equipped with like a whistle function. So when she was describing taking that long, slow breath in and doing that breath hold, making sure that, you know, they don't have a whistle noise that emits during it, because it just means to slow down your breath. And then so for the next one, have them try it with a slower breath in. So it doesn't have to be it's actually a nice, long, slow breath as you described.
And thanks for adding that. I forgot about teaching that. So does anybody have any questions about using the spacers? Or which one to prescribe? No? Okay. So the next thing we're going to talk about are dry powdered inhalers versus using an MDI and spacer. I'm going to put Randy away now. How we choose to use a device is based on many different things. One of the first things that it's based on is the severity of their asthma. We're looking at the child's age. We kind of look at their insurance, how many houses do they go to where they're going to be getting their treatments at. So we get to what medications they prefer, or the patient prefers, or as easy as for the parents prefer. So we look at all those factors when we're deciding on what to give a patient. One thing I do recommend is that if a patient is new to asthma or new to using an inhaler and spacer, is that if you're going to teach them how to use an inhaler with spacer to use their albuterol, it's best to start them with a medication that they're going to take daily that has the same technique. It just makes it easier because it's two different types of breathing that they have to do if you're using the spacer compared to a dry powdered inhaler. So a lot of times we'll start them off that way and then have them transition to a dry powdered inhaler, at a follow-up appointment if they prefer to and they're able to. And so when you're using the spacers, whatever, it's all the same technique. But when you're using a dry powdered inhaler, it's quite a different technique. And to determine if somebody can actually use this, they have to be able to. This is a trainer whistle that we have, and I know that everybody doesn't have one of these, but you have to be able to generate a quick and a forceful breath in. So in order for the dry powder to get into your airway. So this here I have is a practice whistle. If we're considering putting patients on a dry powder inhaler, I'll give this to them to try. If they can consistently make it whistle, then great. They probably can use a dry powder inhaler. If they can't, let's say take it home and practice with it, and then maybe at a follow-up visit they could transition over if the doctors want to switch them over. So I'm just going to show you just to show you how much of a force it really takes to actually get the powder out of the device. So with this whistle, I have to really breathe in hard and fast to be able to get the medication in. So if they can't master that technique, then they're probably not ready for a dry powder device. Some of the dry powder devices that we have are different, and I can really understand why people are confused when they get these devices, because if they're not explained at the pediatric offices and you don't show them how to do that, chances are, and they're probably not going to ask their pharmacist how to use it because they're probably not expecting to get a device that's much different looking than the inhalers they've had in the past. So this one here is a demonstration of an Asthma like twist tailor. And with these, there's a dose counter somewhere, just like there is with the regular MDIs. And with this one, it's just as it says, it's twist tailor. So to use it, you twist the cap up and then pull the lid off. And then the medication is sitting right here in the mouthpiece on top. Can you see that? And so once you have it loaded, it's important that people do not turn it upside down, they don't shake it, or they don't breathe into it because they'll pack the powder inside their inhaler. So when using a dry powdered inhaler, what we tell them, no matter what the device looks like, to hold it off to the side. They're going to first breathe in, exhale out, put the medication to their mouth, and then do that big forceful breath in, hold to the count of 10, exhale out. And when they're done, they just put the cap back on. If they were to do another dose, they would just load it up again. I've seen a lot of kiddos come in with these before that had them when these dry powder inhalers first came out that were given them maybe too young. And they come in, they so jammed up and not working and powder all over them that it's really concerning sometimes with what you see, that maybe this is not appropriate for a lot of kids that don't have a lot of supervision at home, and somebody's helping with their medication, or somebody's just not been trained to use this device. It's confusing. And this is a discus. So it uses the exact same technique as you would with the twist tailor. However, this one, it has a dose counter on top, and then when you use it, you push this back once, and then I don't know if you can see right now, but the hole here is closed because we're not finished yet. So if they took their medication, tried to take it now, it's not going to work. They have to click it one more time, and now the medication is ready to go. So once they have it loaded, it's important, again, don't flip it upside down, don't blow into it, and again, hold it out to the side, breathe in, exhale out fully, and then that big breath in with a nice tight seal around the device with your lips. And then when they're done, they close it here. And of course, we always, talk about mouth care after the inhaled steroids to make sure that they're preventing thrush, and using their spacers too to prevent that also. And just one more device I wanted to show you is these are the Ready Inhalers. They're wonderful because with dry powdered inhalers, you do not need to use a spacer. And with the Ready Inhaler, you do not need to use a spacer. So these are great for kids that don't want to be taking medications carrying a spacer around. So with these, it's really pretty much breath activated because it has a dose counter on the back. There's an albuterol that comes like this, and now Q-Bar comes in the Ready Inhalers. And with these, they flip it down, and then it's really breath activated. So once you breathe in, it's somehow, I don't know exactly how, but it gets the medication where it needs to go. And if they were going to do another puff, they would load it again and do it the exact same way. So that's the dry powders that I have. Does anybody have any questions about that? Let's see, I do see there might be a couple.
Brooke, can I go ahead, or somebody?
Yeah, and then I would like Dr. Marco to review her chat, but please, Dr. Hardy.
Oh, sure. So yeah, mine's William Hardy in Cincinnati. That's a wonderful talk. I learned a lot. And I'll ask this for you and Angela and Ava. What age do you guys first switch to the mouthpiece inhalers? I know it varies probably from patient to patient, but on average, what age are you willing to say, hey, we can start going from the face mask to the mouthpiece?
I usually start around the age of 6 because they seem to be pretty coordinated at that time. And you can tell by their, sometimes the boys are a little bit too immature yet, and they're, or if they have a little bit of ADHD, they might not be quite ready for it because they can't do that breath hold. But usually around 6 is when I find it's a good time to start transitioning them over. And if they don't master it, I make sure that they have the inhaler with spacer so they could practice using the other one at home until they've gotten a hold of it. So they're getting the best treatments at home as possible.
Okay.
Yeah, I usually do 5 or 6. So 5, obviously we have in-office spirometry. So if they can do PFT at 5, I switch them over because, if it's an accepted test, if they're still struggling, I probably keep them on depending on how they did the mask.
Yeah, that seems to be what we're doing too. Like 5 is just kind of when we least think about it, but it's going to vary. Just like you said, we'll have our educator review it with the family, and they'll say, "Oh yeah, they can do it or no." But yeah, if they can do spirometry at 5, they can do probably a mouthpiece. And then my follow-up question: the dry powder inhalers. I kind of try to avoid those, but I wondered what situations you guys, I mean, obviously sometimes you're forced because of prescribers, or the insurers mandate that you do those, but I'm just sort of curious what your guys, like when do you switch to those in your experience?
I'm happy to answer. So unfortunately, recently, many people are going to be experiencing this, probably a lot of primary care providers, you probably as well with CareSource, as well as some medical mutual, things like that. So some of the private commercial insurances have now told us 6 and up, they have to try Pulmicort FlexHaler, which is a dry powdered inhaler. Even though we may not agree necessarily with that age and being able to do the dry powdered. So it's ideally never my first choice, to be honest, but the time that I will use a dry powdered inhaler is often I do it in teenagers who maybe prefer once daily dosing, or they will never use a spacer and they don't like the whole setup, and maybe their technique isn't so I don't know, something like that. Sometimes with Asthma Next, I can get away with the once daily dosing, which maybe will help them if they're really struggling. But now with the ICS Formoterol and Smart regimens, it's kind of, you know, less, I use it less often. That would probably be the main reason, I think. I don't know.
Yeah, I can't even
What about
remember the
ordering-
last time that I taught a patient. Oh, I'm so sorry. The dry powder,
ahead.
like a twist tailor.
I was gonna say, can you order those like in our offices? Because we have some sample ones, but I wouldn't be able to show it on people to how to use the
Dry powder.
inhaler.
I have the devices, and I will have to reach out to see if we can get more samples that we could give out, or that you could request from your drug rep. A lot of times they have the samples, the practice samples, but I don't see them very often because they don't come in the hospital very often. And like these whistles that I love, I don't get anymore because they used to come in, pretty much regularly, like once a month or every couple of weeks, and they were constantly bringing in things. So now if I don't have, like, I'm holding on to the last ones that I have so that I can teach with that. I think outpatients with the drug reps, like our outpatient center, I think they're able to get supplies, I think. So I could find out how our nurses get those trainer devices if you would like to know. And I do know it comes through the drug reps though. And if you can get a hold of at least one of them, at least you can at least show them how to do it, even though they can't do the practice the breath hold in. A lot of times I tell them too is that if they use this device and they think that their child did not breathe in well enough to get the medication in, I will tell them, do not load it again, but just hold it off to the side, have them do the method again, breathe in, blow out, and breathe it in. When I've looked at a dose of this, when you flip it over and you put the powder in your hand, there's such a microscopic amount of medication that actually comes out of this device that if you do not have proper technique, you are not going to get that medication, and enough is lost already in the delivery process as it is.
Yeah, I don't think I realized how problematic this could be until you talk about that.
Yeah, they like I said, and I've seen and I never assumed that somebody knows how to use them. I worked one time on adult cystic fibrosis floor, and I had a patient that was on Advair 500, and I just handed him his medication because he had been on it forever. And so out of the corner of my eye, I looked at his technique, and he opened the Advair, and then with it closed, he went like that. He didn't even open it. He didn't even get the medication was not even in there yet, and then he closed it. And I said, I said, is that the way you always do your Advair? And he said, yes. And I'm like, well, I'm thinking to myself, well, that's probably why you're on 500 then, because you're not getting any benefits of this whatsoever. Yeah. So it's always good. People always say, yes, I know how to use this, and I know how to use it as a home management plan. I know how to use my spacer, but in reality, repeating it at every single visit and just going over and making them demonstrate. Like we make our patients demonstrate, kids that are old enough, how to use their inhaler and spacer by giving the puffs themselves when they're due for treatment. Or we'll make a parent, ask a parent, when they're like at every 3-hour treatments or every 4-hour treatments, for them to give the treatment. So we can see that they know how to do it by themselves and they're comfortable with the technique. So, and we document that because it's important. And then by the time they go to follow up in 4 to 6 weeks, they're either doing it properly or again, they're not doing it quite right. And so they get another chance for review at that visit. And at every home management plan, even though they've given one, every time it's review, because that's really how they really learn to start managing their asthma, and they start correlating those symptoms with the zones that they're seeing. So symptoms and the zones go together, and instead of focusing, I have patients say, well, I have a pulse ox at home. I need a pulse ox at home. It's like, you do not need a pulse ox at home. You need to recognize the symptoms that you're seeing and treat them. Because we have patients that come in the red zone that don't need oxygen. And so that's not really the guide.
Thanks, Karen.
You're welcome. Anybody else? Any other questions?
I think there's a few people left on. I just really briefly wanted to say, just keep in mind when ordering these different medications, many brands carry both a dry powdered inhaler and an MDI. So really paying attention when you're ordering whatever your EMR is, that you're looking at the actual prescription, because there can be confusions. Like Asthma Next does come in an MDI form and a DPI. It should say DPI next to it if it's a dry powdered. So sometimes the confusion comes in just ordering it correctly. So just being really aware of all of the prescription when you're putting it in.
I want to mention one more thing about the Asthma Next, because there's the 2 doses. I think it comes in the 110 and the 220. So with the 110, you can only be given 1 puff once a day, because the 110 only comes with 30 puffs in it. The 220 comes with 60 puffs in it. So it's important that if you need somebody to take 2 puffs once a day, or 2 puffs twice a day, not to give them the 110 strength, just to have them do the 220 once a day, because they'll have to get a new inhaler every 2 weeks, basically, because they'll run out of medication if they need 2 puffs a day. That's one thing we just learned throughout when Asthma just came out. So
Thank you for passing that on.
sure.
Any other questions for those who are still on? Okay.
Well, please feel free to reach out if you have any questions, or if we have lots of handouts, or just you thought of something, you want more information, we could reach out to us. I have my email address I can put out, and I also have my phone number if anybody wants to call or has questions, or you know how to reach Angela, that's for sure.
And me too. And if it's okay, I will forward your information to the group when I email them this week.
That'd be great.
Okay. And this call will be, the recording will be posted. So thank you, Karen, for the good information today. And if we hear anything from anyone, we will have that conversation.
All right, thank you. All right, have a good day.
You too. Thank you.
Bye.
Bye-bye.